So welcome. Thank you all again for joining today's webinar. I'm Ayana Jones, the ID Mentorship Program Manager for the IDSA Foundation. Thank you for joining us for Optimizing Patient Outcomes, Harnessing Physician-Pharmacist Collaboration and Antimicrobial Stewardship. This webinar is in continuation of our ID Mentorship 365 webinar series. So huge thanks to our speakers who we'll introduce here shortly. But before I turn over the program to our moderator, we have a few housekeeping matters. This webinar is being recorded and will be available on demand if you can't stay for the entire presentation. The presentation will be uploaded to the Cooper platform for those participating in the mentorship program, or you can access it and share it via our IDSA Foundation YouTube channel. You'll actually notice that today's webinar is actually formatted as a meeting, so your microphones are currently muted, but please feel free to use the Q&A feature to ask questions during the event. There will be a dedicated Q&A session at the end of the presentation where you can come in and come on camera and unmute yourself. And if we can't get to all the questions during the event, the live event, will do our best to address them in a follow-up email. Finally, as you know, we are on social media at IDSA Foundation across all platforms. Please feel free to post or share your takeaways from the webinar, tagging us or using the hashtag IDM365. So thank you. As a reminder, today we will discuss the crucial role of pharmacists in ID management, particularly focusing on antimicrobial stewardship. Our speakers today will talk about collaborative decision-making between physicians and pharmacists and enhancing patient outcomes within multidisciplinary teams. This webinar will underscore the importance of effective pharmacist-physician collaboration and AMS protocols. Now I would like to introduce to you our moderator for today, IDSA Mentorship and Recruitment Subcommittee member, Dr. Whitney Nesbitt. Dr. Nesbitt is a board-certified infectious disease pharmacist who currently works as the GSK Vaccines Medical Science Liaison for both Tennessee and Kentucky. Prior to joining GSK 2 years ago, Dr. Nesbitt served as the ID and ASP clinical pharmacist specialist at Vanderbilt University Medical Center, or VUMC, for 9 years. During her tenure, she co-led the VUMC ASP and antimicrobial stewardship, antimicrobial subcommittee alongside her esteemed partner, Dr. George Nelson. In addition to her role as the ID and ASP pharmacist, she also started and led the PGY2 ID pharmacy residency program at VUMC as the residency program director. Dr. Nesbitt is passionate about mentorship, particularly in the field of ID, as evidenced as her role within the IDSA Mentorship and Recruitment Subcommittee. And she also continues to contribute to ID education through her authorship within the Mandel, Douglas, and Bennett's Principles and Practice of Infectious Diseases. So it is my honor to introduce you all to Dr. Nesbitt.
Thanks so much for that introduction, Ariana. I really appreciate it. I am Dr. Whitney Nesbitt, and I'm really thrilled to moderate today's webinar, as well as to introduce you to two of my favorite people in this world, Drs. George Nelson and Rebekah Wrenn. They are brilliant, kind, and truly inspirational leaders that I know you'll be anxious to hear a lot more about as we go through. First, I'd like to introduce you to Dr. George Nelson. He's an assistant professor of infectious diseases at Vanderbilt University Medical Center. He completed his internal medicine residency at Vanderbilt and ID fellowship at the Johns Hopkins Hospital. He served as an epidemic intelligence service officer at the Centers for Disease Control and Prevention, with focus on antibiotic use, bacterial infections, and outbreak investigation. He serves as the director of Vanderbilt's antimicrobial stewardship program, which has been designated a Center of Excellence by IDSA. Additionally, he serves as associate epidemiologist for Vanderbilt. Dr. Nelson's major scientific interests focuses on antimicrobial resistance and appropriate antibiotic utilization. He has and continues to serve on advisory committees for the Society of Healthcare Epidemiology of America, the Tennessee Department of Health, and other collaboratives on antimicrobial stewardship and infection prevention topics. He's published extensively and presented frequently at national meetings. He also attends on both inpatient and outpatient infectious disease clinical services at Vanderbilt. I had the privilege of working alongside Dr. Nelson as his partner in stewardship at Vanderbilt for many years. And in the trenches of stewardship, we forged a strong friendship. I learned so much from his incredible clinical acumen, and he served as a mentor to me in so many ways. So thanks so much for joining, Dr. Nelson.
Thank you for that kind introduction. That was super sweet.
Absolutely. Well, now it's my pleasure to introduce you to our next speaker, which is Dr. Rebekah Wrenn. She is a board-certified infectious disease clinical pharmacist and coordinator of the ID Pharmacy Programs, plural, at Duke University Hospital. She is the director of the PGY2 Pharmacy Residency Program in Infectious Diseases and is an adjunct associate professor with the Duke School of Medicine. Dr. Wrenn serves as the co-chair of the Duke Antimicrobial Stewardship and Evaluation Team, which is a part of the Duke Center for Antimicrobial Stewardship and Infection Prevention. Dr. Wrenn earned her PharmD at the University of North Carolina at Chapel Hill, and then she completed her PGY1 pharmacy practice and PGY2 infectious disease residencies at Wake Forest Baptist Health in Winston-Salem, North Carolina. She's an active committee member in the Society for Healthcare Epidemiology of America, the Antimicrobial Stewardship Committee, and the Society of Infectious Disease Pharmacists. Her research interests include allergy delabeling, including penicillin skin testing, outpatient antimicrobial stewardship, urinary tract infections, and duration of antimicrobial therapy. She also enjoys hiking, gardening, and playing soccer. I have known Dr. Wrenn since her PGY1 at Wake Forest. I won't say how many years ago that was, but suffice it to say, we've had a long and wonderful friendship. Rebekah is a brilliant ID and stewardship pharmacist and the kind of leader that anyone should aspire to become. So thank you so much for joining us today.
Wow, thanks, Whitney.
Yeah, absolutely. So we'll go ahead and kick off our discussion. And as a reminder to the audience, please use the Q&A button to ask questions at any point in the presentation. So one thing that I wanted to ask you both, it may not be obvious in either of your bios, but being an ID provider was actually kind of a second career for both of you. So Rebekah, can you kind of walk us through a little bit about how you decided to become a pharmacist and why you specifically chose ID and stewardship?
Yeah, absolutely. So as I was kind of finishing up my college career, I was thinking I wanted to either go into medical school or get a PhD. And I was really fortunate to join the Women and Scholars program at my institution, which was Queens down in Charlotte. And as part of the Women in Science Scholars program, I was able to do an internship at GSK. And I started researching through that internship HIV and kind of postnatal transmission. And it was during that internship that I really dove in and started thinking I wanted to go down the PhD route. I met a ton of PhDs while I was there. But as I continued to work there and work over at UNC a little bit in HIV vaccine research, I realized I was pretty far away from patients, and that was not a huge satisfier. And so it wasn't until my second year at GSK that I met my first PharmD. And she came into the lab and wanted to learn more about kind of what I was doing, which was resistance passaging. And I wanted to learn about everything she was doing, which was running clinical trials. And so my love for HIV started there. My love for infectious disease started there. And then I just discovered this pathway that both merged what I was interested in, being pharmacotherapy, with the clinical aspects of care as well. So from there, I did some shadowing and really realized the PharmD route was perfect for me. So during that experience, I got to see drug development from start to finish. We were a fast pass for a CCR5 antagonist, and so I got to see drug discovery, which a lot of that was actually really helpful in the beginning of COVID when we started talking about cycle times and PCR and things that I had long since thought were probably not going to be super useful to me. So it's kind of funny how, things come full circle. But yes, it was definitely not a traditional path towards the PharmD route. And I think it's unfortunate that not a lot of people get exposure to kind of clinical pharmacy as a career choice for those that are interested in the sciences and in healthcare. There's so many different ways you can take that degree.
That's great. So what got you specifically interested in doing stewardship?
So gosh, that's a big question. So for stewardship, I love stewardship because I see a problem and I can go upstream and fix it, as opposed to seeing a problem and seeing it again and seeing it again. I think stewardship really offers the opportunity to fix problems kind of at a large scale and impact the future in a way that a lot of areas don't offer that opportunity. Because what we're doing is a bigger goal of providing anti-infectives for the future. And so I think being able to solve some problems today that help us to, use them better today, but also think about how we can change people's perspective on this drug class so that we have these options in the future. So it's a bit of a shift from HIV, but as I learned more and more about infectious disease, I merge stewardship with just use of anti-infectives. I mean, in my mind, the two are synonymous. If you're good at using anti-infectives, you're going to be a good steward. And so that's where I kind of shifted from HIV into more of a stewardship focus.
Brilliant answer. I love it. It's so interesting to hear kind of what your path has looked like to being a successful steward. Say that 10 times fast. So George, you were an EIS officer first, right?
I was, and I mean, even thinking about, I did not have a straightforward path. When you were talking about, this is sort of a second career, I was thinking about, it might have been one of 4 or 5, 6 or 10. In college, I was a creative writing major. And so I was going to be an author. And I was working in labs during the summer. And at the end of senior year, I decided, hey, I want to go to medical school. I'm not going to take time off. And so then I found myself in medical school. I was interested in everything. When I'm on a rotation, I thought I was going to be a pediatrician, then, a psychiatrist, and et cetera. And went to Vanderbilt for medicine, and same thing. When I was there, I was doing my medicine fellowship, and I was interested in everything. And then I went to the CDC, and I was like, this is going to be great. I'd done a lot of international work. I sort of mission focused. And so the CDC EIS program was perfect. I was like, I get to, get dropped off in the middle of the jungle and, attack an outbreak and things like that. And while I was there, I really missed a lot of the sort of patient contact. And so it was definitely a 10,000 foot population health view, which was great, process improvement, how do we fix, as Rebekah's saying, sort of these upstream problems. But I also didn't have sort of the satisfaction of actually connecting with patients. And so at that point, I've done a lot of international work, and I actually thought I was going to work outside the United States. And so I was like, if I want to be a primary care doctor somewhere else, infectious disease is going to be super important. And, I also, when I was working at the CDC, I was like, I know all this stuff, but I should know more about these pathogens. And so then when I went to fellowship, I was very interested, as a lot of new sort of infectious disease fellows, in HIV. And I was really looking, because that, was sort of an international global application. And so I was very interested in doing HIV TB co-infection. And that's kind of where my research was going, until I was on service with just some phenomenal mentors, and just seeing how people used antibiotics really elegantly, but also really poorly. And I was like, this is a huge problem. And my mentors at the time, I was just like, if I could sort of clone myself and follow your path, that would be amazing. And so I completely switched gears midstream and started doing stewardship. So much so that my research was in India. And I was like, well, now I'm doing stewardship, so I might as well do stewardship in India. And so, I think it's one of those things where my career has like ping ponged back and forth, but has always been informed by, the step right before. And so in that sense, I couldn't have imagined getting to where I am now, but somehow it makes sense.
Yeah, I mean, somehow it all does make sense for both of you, actually, and just kind of hearing your stories too, how you've been able to leverage your prior career and learnings into what you're doing today, like managing COVID and what you learned there, and then, stewardship in India and how that translates to potentially stewardship in the United States and your career as an EIS officer. It's just really neat to hear how all of that has kind of made you who you are today and given you that experience. I'm also curious, like, George, like, what does a day in the life of a stewardship physician look like?
So there's no singular day. I get this question a lot because people are like, hey, can I like follow you around? And I'm like, well, it kind of depends on what day, right? So, and I should say as sort of a disclaimer, right? I work at a really big academic medical center, and that may be a very different day than working at a community hospital or, outpatient clinic or something like that. But I would say if I were to average my days, I have some patient contact. I have a ton of sort of administrative tasks. And a lot of that is, right, sort of this multidisciplinary stewardship touching every corner of the hospital and really sort of like things coming in being like, hey, we have a problem. And then having to like have a meeting, have emails, figure out the problem. But then also internally, our stewardship program is sort of identifying priorities and targets and then reaching out. And so that's some of the process stuff. And it's actually, I would say that administrative portion from like a physician standpoint is probably a little bit more than I would like. I would love to have more of that sort of patient contact. And that's where a lot of that collaboration with like the pharmacist is super important, because that's like some of that frontline, like contacting patients, being with the teams, et cetera. And so we kind of have to do both and like overlap somewhere in the middle.
Yeah, so tell me more a little bit about like the collaboration that you have with the pharmacist on your team.
Yeah, and first of all, I would say it's great. And it's something that definitely has evolved and changes and continues to change. I've always been like very like a big advocate for championing pharmacy and everybody on our team, right? And so I think like having like pharmacy as like an equal partner in it, and not sort of, I mean, medicine is a very hierarchical thing, right? So it's like, if you're a medical student or you're a fellow or you're a professor, but what degree and how long have you been there and things like that. And that really sort of chips away at sort of what you're trying to accomplish, right? And I was talking with someone and they were saying that, there's kind of a couple ways of management, and there's like the top down, right? Which is like Amazon, like Jeff Bezos is like, this is what you need to do. But then there's also sort of this like longitudinal content expertise where you like try and manage by consensus. And I think that's kind of where stewardship is. And so from my standpoint, like there is expertise that my pharmacists have that I do not. And so really relying on them and trusting in them so that we can come up with, a plan, and that's equal entry because we come out with a better product, and then maybe they're the effector arm. So I don't know if that answers your question, but it's like one of those things where I think it's integral to the success of a program.
Yeah, and having been on the receiving end of that as, your partner in stewardship for so many years, I can definitely say that what he says certainly holds true. I definitely felt like a very well supported and valued member of that team. Yeah, absolutely. And it's very important because I came from a job where I didn't have that and recognized how important that was. So
yeah, I couldn't agree more. And I think George said it so well. I think that even footing on, at our equal place at the table is so important, because I think it allows the pharmacist to feel that support. So when they are making interventions bedside with, non-ID physicians, they feel very supported and are much more confident perhaps in their recommendations than if they don't have a physician that's, really supportive of them. So I think it makes it so much better for the pharmacists that are working with the physician, but it also, I think, makes for a better program, a better stewardship program, and ability to do kind of higher level stewardship beyond just simple bug drug mismatches and de-escalations and things like that.
So Rebekah, as the leader of a stewardship pharmacist team, kind of what does your day look like?
Like George's, it is extremely variable, which I think it's fun. I think it's really, I can't imagine a job where I did the exact same thing every day. So I run the stewardship program from a pharmacist perspective. I have 3 inpatient pharmacists, including myself, that do the clinical kind of day-to-day work for the stewardship program. I have a co-chair by the exact same name as myself, exact same first name, Rebekah Mooring, and just similar to George's kind of interaction with the PharmD team, she is extremely supportive. So we really make a lot of the programmatic decisions together and are constantly consulting each other, and she really values the input of the pharmacist. So for my inpatient stewardship clinical job, I pull a list of patients. I do audit and feedback. So that could be patients with positive blood cultures. That could be syndromic based. So like every other program, I think probably in the country, we have a problem with ASB, or asymptomatic bacteria, and the desire to treat anything that grows in the urine. And so that audit and feedback is, me just going through patient profiles, reaching out to the primary prescriber, recommending alternative therapy. Our team meets at 11 every day. And so that's a time for the physicians and pharmacists to get together and review more complicated cases. So we review imaging together if there's a question, diagnostic question. The physicians also do audit and feedback in the ICUs, and I can talk more about that if folks have questions about that. But the 11 a.m. hour is really for us to get together and kind of, bat ideas off of each other. There's so many different ways to approach a patient case. And so it's nice to go through those challenging cases together and get different input. We do handshake stewardship as well, specifically on the peds side. So I cover adult and peds. And so that just means we go to the floors, we talk to prescribers, we talk to the whole team together, or in the ICUs, talking to the whole team together, both to be visible as well as to make those interventions at a patient level. So something I think I've learned over my career in stewardship is visibility is critical. And so you never want to be the man behind the green curtain or whatever. You want to be out there, and you want the prescribers to understand you're in the trenches with them, and these decisions are difficult. And, antibiotics, as the, 1960s paper, talked about, they're the drugs of fear. And so a lot of times people are using them because they're fearful. They don't know exactly what's going on with the patient. So we do those rounds. And then in the afternoons, I usually try to focus on project work. Because going upstream of these problems and trying to make changes in the EMR are just so critical to not continue to have to change perspectives on results, but try to perhaps make the results not look the way that they do, so that people don't make errors in interpreting them. I also manage the outpatient PharmD team. So that's our HIV and OPAT teams. And so I work in the afternoons supporting them as well, helping to build out some of the programs for long-acting injectables, as well as kind of building out our OPAT program to be stewardly in that area as well. So a mix of projects and patient care. We also round with ID consults, depending on what learners we have on service. So we take a fair number of learners. Never as many as want to come on ID, and never as many as we want to take, because everybody needs some good ID pharmacotherapy knowledge. But a lot of variety.
That's great. Variety is the spice of life, right?
Yep.
So I definitely echo those sentiments that no day looks alike, and it kind of makes it a lot of fun in that way. You just never know what you're walking in the door to. So yeah,
exactly.
that's great. So kind of in your descriptions of both of your days, I've heard a lot of like important factors that could be associated with, a successful stewardship program, like visibility. I've heard you mention technology and leveraging technology, collaboration. And so what do you feel like are some other key like success factors for a stewardship program? Rebekah, if you want to start.
Yeah, sure. I think that having your clinical pharmacy team outside of your infectious disease pharmacist engaged in stewardship is really critical. So prior to coming down to Duke, I practiced up in Richmond, Virginia, at a community hospital, about 780 beds. And it was split between two different facilities about 5 miles apart. And so I really worked to educate the clinical pharmacists that didn't have specialty in infectious diseases to increase their comfort and increase their baseline knowledge of infectious diseases so that we had many more boots on the ground than just myself, because I was running the stewardship program and the only ID pharmacist. And so I think making stewardship a team sport beyond just the physician ID pharmacy team, but also really engaging the clinical pharmacist, frontline pharmacist in all your stewardship activities, teaching them, letting them have the wins. So we always provide our recommendations if it's a rounding team or there's a pharmacist that's covering the patient. We always provide our recommendations to them, and then they make that intervention. And that way, I think we've taught two people at least, right? We've taught the clinical pharmacist, they have to understand it well enough to then translate that recommendation to the primary team. And so I think depth of the program is really benefited by engaging all your clinical pharmacy group.
Yeah, that's fantastic. What about you, George? What are some thoughts that you have?
Yeah, I mean, I think there's so many different elements that are important to a program, but the ones that sort of come to my mind initially are structure, relationships, and communication. In terms of like relationships, like this gets to what Rebekah was saying in terms about like visibility, right? Where are these recommendations coming from? And, is it a credible source? Do they trust the person? And so much so when I came and joined faculty at Vanderbilt, my mentor said, for the first 6 months, when you get there, you're going to be like rearing to go and have all these ideas. And she said, don't do anything. She was like, just meet people. And, I'd done my residency here, but I think cultivating those relationships is super important. And you feel like maybe you're like not doing anything, but it pays dividends as going down the road. And then communication, right? So I think, and that's one of those things, hearing about Rebekah saying, we meet every day at 11 to discuss this. It's like, that's super important, because whether or not this is a process measure or a specific patient, if you are coming sort of out of left field, it's going to be really hard to land whatever that intervention is. And so if you're sort of like transparent, you're like, well, you ask and you listen, right? So like, well, what are you concerned about? Oh, me too. Like, let me help you get there. And that's something that I think, it's important in like every part of life, but it's not something that is like focused on in like medical training, right? Like how to communicate and team management. But I think it's super important. And then I think, from the structure standpoint, when you have an issue, right? Like, or you need resources, or you need IT support, like, where are you going? And in your general like team, it may be very easy, right? You're like, well, this pharmacist is going, is covering the ICUs. And if they have a problem, they're going to come back to our team. We're going to fix it. But I'm talking about sort of more like the global picture, where you're like, man, we need somebody to do outpatient stewardship, or we really need, another pharmacist to join the team. Who are you going to, right? Like who's got your back in the institution you work? And I think that is something that if you can define and sort of have like those champions when you run up against a barrier, and that can be, a clinical patient, a program, a, programmatic need, it's really going to sort of make that a much more efficient process.
Yeah, that's fantastic and really insightful. I think that it's really helpful for our audience to kind of hear what are some key success factors for stewardship programs and what they should look for, maybe as they're pursuing different roles at different institutions. One thing that I've heard you say is like about collaboration with other pharmacists and teams. Is there maybe a patient case that sticks out in your mind and in which stewardship really had a direct role in impacting that patient's outcomes? George, do you want to start? Is there something that comes to mind?
Yeah, I mean, I could pick something from this morning or last week or, but one case, which I actually think you were involved with, and I use this in like a ton of presentations because I think it really encapsulates things. And I mean, I remember the patient's name and everything, but there was a patient who had a port in for Crohn's and was getting chills when it was being accessed as an outpatient, came into clinic, blood culture is drawn, they're positive for Klebsiella oxytosa, and they paged the primary attending, never got the page, but stewardship was sitting there and doing surveillance. And so this is an outpatient who has a positive blood culture. And we had, by working through the program, like we are going to follow these sort of critical gaps, we're able to step in, get that patient admitted on antibiotics and avert a potentially lethal clinical situation. And so I often will lead with sort of that story when I'm sort of talking about something and people are like, oh my gosh, like that's amazing. Like you helped this, young woman who was a mother of one just by your quality process. And I was like, yes. And that was one of 42 similar instances over the last 18 months. And then they're like, oh my gosh. And so, I think that is sort of a process that was in place that we have an escalation sort of paradigm, and the person who benefits is the patient.
Yeah, absolutely. And so one thing that I heard you say too is it sounds like leveraging technology and tying in microbiology as well. Are there opportunities to collaborate with microbiology departments within your stewardship programs?
Yeah, absolutely. I mean, I think there's so much in an electronic medical record, but there's just so much data that it's very difficult to monitor everything that's going on. And so how your sort of surveillance, your information technology is set up, and decision support or education that's embedded in that, it doesn't replace sort of the human interaction, and but it is sort of a necessary complement. I will say sometimes in talking to administration, they sort of assume well, if we just build some rule or some pop-up, that's going to solve the problem. And so we'll just leverage information technology so we don't need to get more personnel or, boots on the ground. And you're like, well, it's kind of both, right? IT is incredibly important to do what we do, but it's not sort of the magic bullet.
Right, absolutely. Yeah, well said. Rebekah, do you have a patient case that kind of comes to mind for affecting patient outcomes?
We have so many, and so similarly where either blood culture becomes positive and people are deeming it contaminant when it's not. We had on Friday someone come in, they grabbed a urine and it grew Staph aureus. No blood culture was obtained, so we called really promptly, and they went ahead and put him on Bactrim. We advised that was probably not the best solution, that they really need to get blood cultures before putting them on antibiotics. And lo and behold, they had a Staph aureus bacteremia, which, as you guys know, has super high mortality, and staph in the urine is an indication that you need to be checking the blood as well. I think as George was talking about the connection with micro and how you need both, we've recently done an evaluation where we had a BPA or a best practice alert fire within Epic to our team only for patients that did not have pyuria but had an antibiotic for a GU indication, a genitourinary indication. And we found in that cohort, there were about 6 patients that actually had bacteremia. And so if you had the BPA firing to someone that maybe wasn't looking at the whole picture of the patient, they could act erroneously. We got that BPA and know that, you know, sometimes folks with stones don't have pyuria. And so we're always looking deeper at them. And so I think it's really important as we move more towards opportunity for AI or the opportunity for the electronic medical record to evolve to give more alerts, that we just have to be really careful. And you've got, you know, really careful and realize that you need people to interpret that, because ID is just not black and white. The same result for one patient is not going to be the same clinical kind of scenario or clinical action that another patient would require. So I think it's really important to kind of keep that in mind.
Yeah, absolutely. I echo how important that is for sure. Thanks so much for sharing that. Those are really impactful stories and so interesting in terms of like how on a daily basis you're directly impacting patient outcomes. So I appreciate you sharing that. You know, one thing I know we're kind of running into some time here and we want to open up to questions from the audience. One thing that I wanted to ask you is like, how would you advise aspiring stewards or, you know, ID physicians or pharmacists that are thinking about stewardship in their careers? Rebekah, do you want to start?
Sure. I mean, I think for a clinical pharmacist, I think that doing a residency really gives you a leg up to fully understand kind of some of the diagnostics. I say fully, I shouldn't use that word, but to understand better some of the diagnostics that go into ID just in general. I think that's one thing that we really put our residents in front of our ID physicians to see the bedside diagnostics, because often as a stewardship pharmacist, you're really evaluating diagnoses. And whether, you know, we're trained that or not in school, you're doing it on a day-to-day. And so it's really important to understand some of the basis and then have, you know, support as you need it. So I think residency is really important. If residency is not obtainable, I think, you know, there's some really great training programs out there. You can also learn from having a great mentor. So partnering up with an ID pharmacist to kind of learn how to approach these patients. We teach our residents and our students that come on rotation how to think about an infected patient. And these are the resources to use. So I think you can learn those things as well from mentorship and having a great physician partner as well. And then having support and, you know, backup for when you get into an area that you're not as comfortable with from an infectious disease standpoint. You're never going to learn it all. So, you know, you don't have to do a residency. And when you leave your residency, if you still feel like there's more to learn, then you've done a good job, because there's always more to learn. But I think there's some great mentorship programs out there through SIDP and a couple of others.
Fantastic. What about you, George?
Yeah, I think I was just sort of thinking back to like my own journey and like what do I wish that I would have known. And I think, you know, at the start, like you don't know what you don't know, right? And so I think the first thing is just being transparent about that, but then really sort of trying to look under the hood, like what is stewardship? And I think when I see learners of all levels, you know, medical school, even like high schoolers who are just kind of like trying to figure out the medical field and things like that, it's not just, you know, what is sort of the textbook like answer on the test, right? And that may be what initially piques your interest, right? You're like, I saw this patient who had this crazy infection, and so I'm super excited about ID. But understanding sort of what are those day-to-day operations, like what is stewardship, right? Because this is its own sort of niche specialty within ID, and so there's a ton of crossover. But when we have fellows who express interest in stewardship, and there's a ton of them, right? Because they're like, this is something that is going to be very important as they move through their careers. We have sort of like an operational training for them. And that's like, you're joining the meetings, you're seeing all the stuff, as Rebekah's saying, that happens like behind the curtain, right? Like, you're not even aware of like how many discussions, emails, and like figuring things out to get to how do you get that BPA to fire, right? And it's like, that's going to be part of your job. And if that's something that you're like absolutely hate, it's important to know. Or you're like, oh, I can see like how the gears turn to actually get there. And so I think that is something that's super important. And like mentorship comes a long way, right? Like for somebody being like, hey, let me point out the things that you don't know, or you're going investigating to kind of figure that out, to be like, is this something that I'm actually interested in, like as part of my career?
Yeah, that's so important. And I promise to the audience, we did not ask them to plug mentorship, but they have. And I think it just echoes how important that is and how you can find mentors no matter where you are within your career, whether you're a seasoned professional, just wanting mentorship in one specific area, or you're kind of nascent in your career and trying to really understand what paths are out there. You can, seek out opportunities to chat with individuals like Dr. Wrenn and Dr. Nelson, who have a wealth of experience in a lot of different areas that can kind of help you navigate that. One question I want to, it looks like Rebekah, you're answering Stephanie's question. But I mean, I just, since it's kind of in line with what we're currently talking about, what did you think about her question about other ways to get your foot in the door in the field of ID after graduating from pharmacy school, other than doing a residency or fellowship?
Yeah, I just put in there the SIDP Stewardship Certificate Program. I think they do a really good job with this program, and in that you have to do an active project as well. And so it gives you some exposure to the program management aspect of it. But I think, getting in and reaching out to a stewardship program that's affiliated with your hospital, and letting them know you're really interested in kind of better understanding what it is that they're doing and seeing if you can shadow in that area. I personally think everyone should and can be a steward, even in the outpatient setting, even in retail pharmacies. I think there are some really great studies that have showed pharmacists intervening in retail pharmacies makes a huge difference in stewardship. So whether you're, there or long-term care facility, or inpatient at a smaller hospital that doesn't have an ID pharmacist, there should be someone that you can reach out to and start learning the ropes. DASON as well. I'm not part of DASON, but it's the Duke Antimicrobial Stewardship Outreach Network, and so they have kind of stewardship liaisons that go into hospitals and help them to find these opportunities for projects, and then do a ton of education, which is something we do for our pharmacists as well, to help them feel more comfortable in making these decisions and recommendations. And so you can also work with a liaison group. I think there are a couple of other places around the country that also have these kind of mentorship programs where they guide you, but you're the one doing the day-to-day clinical work. They just help you analyze your data and come up with big projects to do.
That's great. It's nice to know that those resources exist. And you kind of touched on educating pharmacists and empowering non-ID trained pharmacists in stewardship activities. George, what does that look like within the Vanderbilt system?
In non-stewardship?
Mm-hmm.
Yeah, I mean, I think there's no singular track. And so when we are like looking at educational curriculum and stuff like that, some of it is like the building blocks. Like, here are things that everybody should know, right? What's an antibiotic or an antiviral or something like that. But then, and this gets again to sort of like understanding like the person who's coming to you, like what their interest is. And so we sort of spend a lot of time trying to figure that out, because if somebody comes to me and they're like, okay, take me through the path, and you're just going like what you did for the last person, you're probably going to miss out on sort of really leveraging or like expanding on like that person's specific interests, passions, and like, what they're good at. And so there's not sort of a singular path. What I will say though is, after doing that like a number of times, we end up having sort of like a pick list of like, here are things that like you could go and like learn more about subject A, B, or C. Because it does get very difficult to say, like, if you're gonna have 100 different learners come in and they've got 100 ideas of what they want to do, well, you've only got so much time. But it's kind of the marriage between, what are you interested in and what can we like support. So it's not just like, here's the one project or the one path, because that's like a square peg in a round hole.
Yeah, I mean, it sounds like from both of what y'all are describing is like, it sounds like there's individualized education and kind of like almost at a point of care where you're seeing a patient care issue that you want to communicate to the pharmacist, then to then empower them to make that recommendation on the patient's behalf to the team. So sounds like there's some education that kind of happens in that perspective. Do you also do some didactic sort of education that's more broad in scope, kind of as you were alluding to, George? Rebekah, do y'all do some of that at Duke, where you provide more didactic education?
Yeah, we definitely do. And you hit the nail on the head with that, the daily education component of like the clinical pharmacist will often make recommendations with the same scenario that you educated them on in the past. And that's why we kind of go through the clinical pharmacist to make those interventions, to Gene Gibson's question. So we also do more didactic teaching. We do that through our residents. We also provide education on a monthly basis to our clinical pharmacy group. And it's really just like bite-sized education. So this is something we've added to our custom ID, which is our ID website. And so this is why we want you guys to know about it in a very short kind of little snippet. We also use that custom ID, which I love so much, and was a new thing to me when I came down to Duke about 8 years ago now. But we do a lot on there as well. So we have a 2-page duration document where we condensed all the hundreds of pages of IDSA recommendations into 2 pages to really help the learner kind of, this is the starting point, this is where I need to go, and then I need to look at it further. But just to make things easier for them and then build upon that. So we try to do a lot with our custom ID and update that as well. And then another thing I think we do for education, besides that audit and feedback kind of daily stuff, is taking learners on rotation. I think we build a deeper base as well when we get residents in the trenches with us, and teach them how to steward, teach them how to approach an infected patient and kind of clinically think through them. And there's so many of the residents, either first or second years, that come through our rotation and just like marvel at the fact that they shouldn't just trust what's in the progress notes, that they should actually dive in and make the decision for themselves. Is this patient infected or are they not? And so for us, it's really kind of shifting the way that they approach doing just a patient review. So we do it on a multitude of ways, but I think that didactic teaching is important. It's just not sustainable. So we've got to have that kind of daily intervention to reinforce these things that we're teaching.
That's great. And it's good to hear how empowered these clinical pharmacists feel to learn from that and then to kind of develop that skill set to make those interventions on their own in the future. Yep. That's really great. One question I have for both of you. So you're both at large academic medical centers, but you have different practices and both recognized as, centers of excellence in stewardship. I think this is a great question from Justin, and he asks, how have you successfully advocated for pharmacist resource expansion in stewardship, or do you have any advice for best strategies with decision makers and C-suite leaders? George, do you want to start?
I love this question. I mean, I think this is like something that through trials and tribulations, I sort of like stumbled back into. So, you know, when you say like successful strategies, I don't know if I can just like list them off, but I can tell you that I've like learned a lot of lessons from failure. So I think one of the big things is understanding, like when I talk about the structure, so like who are you actually going to? And then I think the other thing is this is not a academic request, right? Where you say like, here's a meta-analysis or here is this thing that demonstrates how good stewardship is. This is a business pitch. And so you have 10 slides, maybe you have 5 minutes, something, and you have to be like, know your audience and what is going to register with them. And that is very different than like what's at the bedside, right? When you're talking to a provider, you're talking about quality and like, we can, you know, this is going to be better for this patient. You're talking about how am I going to meet like the hospitals or wherever you're practicing, like their goals with more resources for me, right? Because you're competing in a very difficult environment for resources. I will say, so there's a ton of information out there, and I don't want to like plug myself or anything, but we just did a review article that basically talks about how do you go and like leverage some of these things for resources. And that came out in like the last 6 months or so. But that was something that like was born out of the fact, and Whitney knows this, that like I was giving like 20 presentations a year trying to get more resources, right? And so it's like, I was like, how do you do this? And so I'm happy to kind of like walk you through that, but it's a really long discussion. But I would take a look at like some of those review articles that kind of like walk you through the step-by-step of like how to gather that information.
Yeah, I don't have any PTSD from that experience at all. No, I'm just joking. I'm just joking, everyone. I loved being a steward for sure. Rebekah, how have you kind of navigated those challenges within the Duke healthcare system?
Yeah, absolutely. I mean, George hits the nail on the head. Like you are competing and against a huge pool of people that also want resources. And so you have to know what the institutional priorities are and really plug into those. So is your institution, you know, is the length of stay just driving them crazy? Can you figure out a way that these clinical pharmacists are going to help with that? Is safety a big issue? Can you, point to some of these cases that you've had where safety has been compromised? And, in some cases, you can point to information out there where there have been large suits that have resulted from improper care for patients as well. It's obviously a Joint Commission requirement, and there are some studies out there that allude to how many pharmacists you need to successfully do stewardship for the bedsides that you have. So you can use those as well. I haven't found that to be super successful. And then if there's a cost component of it as well, is there any way you can, tie that in? I don't ever want to proclaim stewardship as a cost savings initiative, but if it wins an argument and, good stewarding is going to reduce cost, I'm certainly willing to use that because that's what speaks to the people that are making the decision. So we have used cost savings and cost avoidance to advocate for new positions as well, and been pretty successful for that. So you just have to know what's going to resonate with the C-suite. And so having someone, that is knowledgeable of what those initiatives are, that's going to advocate on your behalf, as well as kind of help lead you down the path of success is really important. And a lot of times that's the director of pharmacy that can kind of give some insight to that.
Yeah, so just like summarizing some of that a little bit, because I think that they were excellent points, that I think that it's helpful to collaborate with leaders within the institution to kind of understand what the needs are. So then, even though it might be some trial and error, and you have some lessons to learn from that in terms of how you next present that best case to garner those resources that are needed.
Yeah, absolutely. And one thing, Whitney, that I forgot to mention is we partner really closely with infection prevention, and they are advocating on our behalf all the time. I mean, every time we do a presentation together, they just highlight the importance of the ID pharmacist and the stewardship team and really advocate on our behalf. And we do the same for them. So I think, we talked a little bit about micro and that partnership, and they can advocate for you as well. But the infection prevention group can be a key advocate and often have very high level kind of C-suite exposure as well.
That's great. We have about 2 more minutes left before the close. And I think that there was another good question that kind of came in prior to the start of the webinar that I'd love to get your opinion on. So we talked a little bit about collaboration between the ID pharmacist and non-ID pharmacist to, expand your breadth of connection. How would you address a situation in which you actually had to get a physician on board to make these changes, whether it was your lead stewardship physician that's been designated with the task of kind of co-leading this, or whether it's just a physician that you're trying to collaborate with where there might not be a clinical pharmacist on that team? George, from your perspective, what does that look like? How would you like to best be approached?
Yeah, this comes up all the time, the reluctant steward, and whether or not that is the stewardship doctor or the ID doctor or the surgeon or whomever. And so how do you sort of bring them into the fold? And I think it gets back to some of the things we've mentioned just about like a programmatic approach, because you really have to understand what that person, like what drives them. The same way that you want to understand like what hospital administration is interested in and sort of pitch to that. It's the same thing, because if your whole thing is you're like, we got to decrease meropenem use, and this guy uses so much meropenem, so I'm going to hammer him over the head about antimicrobial resistance facts and cost of the medication, all this kind of stuff. But he's really concerned about the patient population being very sick or have resistance or whatever. That sort of pitch is not going to land. So what I sort of do is I sit down and I'm like, we looked at use across everybody, and here's data, like, what do you think, right? And then I sit back as like a sounding board to understand where they're coming from. And then that's where you start using that relationship to go forward. And so there's not an easy answer, right? It's like, how do you get somebody to come over to your side? And oftentimes, like from a negotiation standpoint, it's not A versus B, or we're going to like barter until we get to the middle. It's expanding the pie. What's the third option, right? And you don't know that until you talk to the person. And that's kind of where I would leave that.
Yeah, collaboration is key. Yeah, absolutely. Well, I know we're just about at time. I just wanted to say thank you so much to you both to coming on and sharing your expertise and wisdom with the mentorship committee and everyone on the webinar today. Thanks again. Really appreciate it.
Absolutely. Thanks for the invite.
Thank you.
Awesome. Thank you all. Thank you so much. This was an amazing discussion. I think we'll get a lot of, it seems like we've already gotten a lot of great feedback. So thank you all just for, for agreeing to present. And so we'll close out with that. Just wanted to make sure if we could just share the slides really quickly. So again, thank you to Dr. Nesbitt and to Dr. Nelson and Dr. Wrenn for presenting today. We are, if there were any questions that weren't answered, please feel free to just reach out and we'll try to get them answered for you. The last thing is that we are, again, on our YouTube channel. This recording will be uploaded tomorrow. So you'll have access to all of the webinars in our series, but also this one tomorrow. And then our next webinar is going to be on IDSA and HIV/MA programs here at the foundation. So we'll just go through all of our other upcoming programs, our active programs now, and upcoming application dates and things like that. That's happening across the foundation and across the society as well. So that's scheduled for April 16th at 2 o'clock. And finally, we post about any upcoming webinars and things. We're posting about them now on social media. So give us a follow there. And yeah, you'll be notified of the rest of the webinar series. So thank you again, everyone, and have a wonderful rest of your day.